Okay, good morning, everyone. Thank you for the time and thank you for joining us. Thank you for that very kind introduction. As you said, my name is Rian. And yes, I'm currently here in the UK where I commenced with a new role. But majority of my experience and all the previous years I spent working around Cape Town. This specific project that I'm going to be talking about today, I did in collaboration with the NGO Jelly Beans. So they are situated, they've got a branch in Pretoria and a branch in Cape Town in Tableview. Jelly Beans is a child trauma center. They work with children that have experienced many different forms of trauma and abuse, neglect throughout their lives. And one of their focus points is on working with child sexual abuse as well as inappropriate sexual behavior that is displayed by children. So I'm going to move over to the PowerPoint. You can just indicate if it is reflecting on the screen, and then I'll take it from there. Working with Jelly Beans, I was involved doing training of other professionals and also doing therapeutic work with inappropriate sexual behavior displayed by children. So we ran a number of therapeutic groups in facilities, and they also, do similar work in the office. What happened is we designed and implemented this very comprehensive training program that addresses inappropriate sexual behaviors, or ISB, by children in group home settings, and we designed it specifically for care staff. Now, the program aimed at developing personal insight, developing resilience, and specific knowledge and skills that's essential for the management of ISB. And we are also here proposing a paper to reflect on our successes and shortcomings from this training program. I think it's very relevant when you roll out training to not just present it and move on, but also to go back to reflect on it, to see what other needs come from the training. How can you further assist those that you have trained? And is the training effective? Is it working? Are they getting what they need to get out of it? And are they seeing success in implementing that which you have now, the skills you've provided, the insights that you have now provided? So that is very, very important for Jelly Beans as an organization. And that's sort of the crux of this proposed paper with myself and Dr. Joan van Niekerk. So a little bit about the sort of background or the context behind this. The project started in the beginning of the year with a training manual that we developed for professionals. It was specifically focused on social workers at the time in dealing with inappropriate sexual behavior. I'm not going into detail explaining why that is important. I'm sure all of you can agree. Now, this training tool that we developed was based on a number of formal sources, academic sources, but also on years of experience, on collections of notes, on prior training materials, from Jelly Beans, from Edith Kriel and Marika Rademe from Jelly Beans, from other colleagues such as Renee Wolof, who's an attachment specialist, Shahida Umar from the Teddy Bear Clinic, Dr. Joan van Niekerk, who's an advocate, from Childline, and also from myself and my experience in the youth justice field. Another reason for us developing this training program is the number of referrals that we have been receiving from specifically from facilities and the number of incidences of ISB that occurs at facilities. Also with, to use a very simple way of looking at it, with staff reaching out saying they're sitting with their hair in their hands in their hair, not sure how to deal with some of these matters. And furthermore, there's also where we found there to be a lack of training opportunities on this topic specifically. People are afraid of talking about sexual behaviors by children. There's a lot of professionals that deal with the victims of sexual abuse, but once children start displaying problem sexual behaviors, it is very difficult for many professionals to find it in themselves or to be comfortable to address that. And in the end, these children are most often just as traumatized as many of the victims. Many of themselves have been victims, and there are a myriad of factors that lead to behavior that can be considered ISB, and even to the point of what is criminalized, so sexual offending, to call it that. So we targeted carers specifically in the facilities. Now, there were very specific reasons. So initially we started with this training program for other social workers, Then we shifted to look at carers specifically.
Sorry, Rian. I was just checking, is the slides meant to be on the next slide? It's still on the front of it?
No, not yet.
Okay, okay, sure.
Yes. No. The fun and the interesting stuff is what I'm sharing with you guys myself. The slides are there's just a little bit of background there.
Okay, sure.
But there will be a few relevant slides here and there.
Okay, sure. Sorry, continue, please. Thanks.
No problem. So yes, as I was saying, we decided to look at carers. Now, the first reason is when we do therapeutic work, we found it very effective when you include the parent or the caregiver in the therapeutic work. So now we looked at the nature and the contact that the care staff, child and youth care workers, etc., have at these facilities with children. In other words, the proximity, to the children versus the proximity of the social worker or the manager or the therapist or even the outside social worker, how often there's contact. And we found it that, the idea was, or the hypothesis, that by training the care staff, we could the impact would be a lot more effective. They are the ones looking after the children. They know the children personally. They spend hours with them. They see them all the time. So that is sort of the rationale behind how we got around to this. Over the past few months, since between March and August, we presented this training at 13 child and youth care facilities, and 84 care staff members completed the training program with us. Right. So I think, when you do training, you have a lot of ideas, things going around. Then when you try to put it in a research format, in a publishing format, you have to also now say, look, what did we actually try to achieve and what do we want to prove here? So one of the big questions that we have is, can we prevent or limit inappropriate sexual behaviors within a facility by training the carers to, number one, better deal with the incidences when they do occur, and to also improve how they prevent things from happening? The thing is, we know that children sneak around, they plan, they keep their eyes open on the carers, on the staff, on whoever is supervising them, and they wait for that moment, whether it is stealing a biscuit from the kitchen or engaging in ISP. They look for that opportune moment. And if you have one care staff, one person looking after children, they can't watch them 24/7. So we want to see how can we improve their prevention strategies. Our training was conducted over 12 hours, so it's a 12-hour training program, and we decided to provide it over 4 3-hour sessions that we ran. Most of the time we ran it over 4 days, so it was 4 Tuesdays over 4 weeks, and then also one of our training groups we did over 2 days. So we had the 4-hour session one morning, one afternoon, and the same the next day. Now, one of the reasons we decided to do it like this is for better dissemination of information, to prevent that information overload that you often have when you go to a training full day, 2 full days. You get a lot, you don't have time to work through it, you don't have time to chew on it and go back to the trainers who now are the supposed professionals, the experts that you want to ask questions and learn from. We also did it like this so that the carers can start to actually practice what is learned while still in the training program, and to try to use these things for inappropriate sexual behavior, and also maybe for general problems. Many of the skills that we taught are transferable, and also to use many of the therapeutic tricks and tools that we presented to them. I'm going to talk more about those in a second. Furthermore, doing it over a few days, over a few sessions spread out over a few weeks, allowed them time to reflect on the training and using the skills, and then to come back and ask us questions to say, look, tell me more about this, or, I tried this didn't work, how can I adapt it? Or even coming back to tell us, well, this, trick or tool or whatever worked really well. Thank you for this. Tell me more about this. So we found that to be a very, very useful approach. And at the same time, it gave the carers, another reason was carers don't often have 2 full days available to attend training. So this allowed them, that morning off once a week where we could do the training. And we focused a lot. I'm going to go into the details a little bit, but I want to actually get to findings of our follow-up. That's the very, very important thing of our proposed paper. But this also allowed us to, have them sort of removed or outside of their normal working environment for a couple of hours. We focused a bit on self-care and on debriefing as well, because we figured that's a very important thing for them to also be taken care of while we now go through this new information and this training. So, as I mentioned, each of the trainings had, or each of the sessions had 3 facets to it. And so the first part, the first hour of each training session, we focused on debriefing and self-care, which is very important. And we wanted to create that opportunity. And we also did a bit of skill development, providing them with a couple of what we call therapeutic tricks or therapeutic tools. And the important thing here is that, just because you're not a therapist does not mean you cannot have a therapeutic impact. Therapeutic impact in terms of assisting a child to change how they think and feel about a certain situation, and also then how they behave, by having a little tool that helps them to relax, having a tool that helps them to, to contain children that go through certain things, whether they're angry at another child, whether they've been a victim, whether they are being confronted because of alleged ISB. And remember, when you confront any person on their sexual behavior, child, adult, whether it's appropriate or not, it's embarrassing, it's uncomfortable. Whether that it's something wrong or not, you're going to find resistance from any person. So you need to find a way, to contain them, to help them calm down. So we have shared a lot of tools and tricks with them. That's based on a lot of attachment research, using bubbles, using glitter jars. Some of our other tools is using our therapeutic stories from our Voices of Hope book. And also a very, very wonderful tool is the Our Bodies book from Jelly Beanz. And I'm going to share also a couple of quotes, feedback that we've received on people on how they've been using these tools to get the conversation started with children. And we found, just quickly running to the end there, they found that by having open and regular conversations, they start to notice less problem behaviors, because children are, feel more comfortable to approach them, to ask a question, to say when something's happening, where something is bothering, or when the child themselves are having conflicting or concerning sexual feelings and they're not sure what they're going to do with that. So yes, this range of tools was very, very useful. And then the second part of each training focused on the specific session, the content that we covered there. So our program had the 4 sessions, well, the 4 parts, as I mentioned. So the first day, we focused on an introduction to inappropriate sexual behavior, where we basically looked at defining and understanding ISB, and also addressing personal reservations. When you, as a person, as a professional, as a carer, deal with inappropriate behaviors, especially sexual behaviors, and you yourself have reservations because of beliefs, your background, or your own traumas, it is very, very important for that to be addressed first before you engage with a child. Otherwise, you're not going to be effective, and that is not fair towards the child that you're working with. So that was a key part of our introduction. Our second session looked at sexual development and sexual behaviors, looking at myths and false beliefs, and very important to help the carers to distinguish between what can be considered typical sexual behaviors, what is more atypical sexual behaviors, and when does the behavior become harmful, or in many cases that there's a criminal aspect and a matter of reporting. We found in talking to the carers that a lot of them say that they had this overreaction. They would often even over or underreport incidents because the underreporting, being scared of getting into trouble themselves, overreporting a simple thing, having a child, putting their hands in their pants in public and feeling, okay, I don't want to get into trouble for this, then doing a reportable incident on that. And we found in the feedback them really relaxing on understanding what behaviors, yes, it might not be appropriate, but it's not necessarily harmful or concerning or even criminal for that matter. The third session focused now on my speciality, my thing that I enjoy the most, which is the child justice system. And this is also what many of the carers enjoyed the most. Many indicated that they really had no real idea of the complexities of dealing with the child justice system, looking at what does the Children's Act say and the Child Justice Act and the Sexual Offences and Related Matters Amendment Act about these things. What about mandatory reporting? What is their role if a child goes to court? A child living with his family would have a carer and a parent with him when he goes to court. In many facilities, you'd have the social worker or other people from management attending. Not all facilities would send the actual carer, which I think is quite lacking, because that's the person that really knows this child personally and knows them well, the one that's taking care of them. And we also focused a lot on the type of offenses, how to distinguish when there are criminal matters, how they should be dealing with the children, what principles they should be following. Because that's the thing, a lot of professionals have this idea, once you've reported the matter, then we have to wait for the court. And as we know in reality, things take a lot of time. And now you have a child sitting, going to court once a month for the next 6 months, receiving no intervention and no assistance, where at the same time, a trained carer can start to address some of that child's own traumas, their concerns, their worries, doing a bit of education, doing a bit of support, and making sure that the child understands what is happening. And also, in the end, we want children who go through the criminal system not to be punished, but to be held accountable. We want them to learn from their experience. We want them to take responsibility. And by having this punitive approach, they're scared of it, and that makes them angry, and it makes that they don't want to, and it leads to them not taking responsibility, which is a big problem. And by having them understand and have that carer understand what's happening in this process, you allow this child a better opportunity to actually take full responsibility and to learn from their behavior, and also to understand why it is wrong or bad or harmful towards another child, to allow them that opportunity to learn from that. And that's what, when my colleagues are going to talk about our therapeutic work with children later on, children in facilities, and they're often naive about the impact that their behavior has, or very naive about what behavior can be considered criminal. Final session focused on prevention and intervention. So how do you talk to children about sex and sexuality and inappropriate behavior? How do you deal with that pushback and that resistance? And then, very important, looking at prevention and intervention strategies. And we know that prevention and intervention overlaps a lot. With children that have a bit of risk, that have displayed ISB before, children that haven't, but that are exposed to other children that are prone to display ISB. Right, I hope everyone is still there, still doing well, and following along. So back to our research paper, looking at our methodology followed in this. We want to know, is the training valuable? And this is important because for us, it's a moral thing. We want to roll out training that is extremely useful, and we want there to be a change in the lives of the carers and the children that they work with. That is really, really important for us. So we want to determine if the training improved the carers' understanding of inappropriate sexual behavior. Has it improved how they approach or how they respond when there are incidences in their whether it's the room or the house or the specific setup that they have, and also looking at improved prevention strategies that they have. And then the second thing is to determine further training and support needs going forward. What is our role? How can we continue to support them? And what other relevant topics do carers need to learn more about? And it's important for us to find this out, so that even if we're not doing this, so that we can get the information and the finding out there for others. So our data collection had two facets. First was our feedback after immediately after the training. So every one of the attendees completed that for us. So yes, we've got this non-probability sampling working with our whole population. It's very focused, very specific. And so the feedback after the training, two main questions: what was valuable? What do they need to learn more about? Then, big important thing here was 2, 3, 4 months down the line, we had focus groups with each of the facilities. So we went around each of the facilities and we spoke to 2, 3, 4, or 5 representatives of those carers that attended the training program in focus groups. Doing a semi-structured interview, having a very qualitative discussion, and collecting information on their accounts, collecting information on their, their stories, their examples. What have they been using? How effective is, the My Body's book? How do the children respond to that? How effective is the Voices of Hope? Using those therapeutic stories. What do the children ask them about it? And have they now, been approaching this this problem or this perceived problem of ISB in a different way? 10 of the 13 facilities provided feedback to date. One of them, it is currently still too soon to collect feedback. And 2 of the facilities have not responded yet. So that is where we are now. So we've got data from 10 of the facilities, that we've done these follow-up focus groups with. So just looking at the time there. So going to our findings and moving forward with our what hopefully will be a publication. We had a lot of positive response, and when you do research, and when you do training, when you develop, when you reflect on yourself, when you want to be critical of yourself, and often if you get a lot of positive feedback, that's a very good feeling. But hopefully you also have something that you can build on and improve on. But I have to admit, our feedback was quite overwhelmingly positive, with very, very specific stories by all of our focus groups on changes in how they deal with the problem or with incidences of ISB. A big distinction between them being able to say, I used to freak out when this happened. Now I understand this is more typical. I can maybe talk to a child now about this. And one of the things that was amazing for us is how they now, the carers say that children are, approaching them with questions where they wouldn't do that in the past. And that is really what we want. So looking at some of our feedback, some of the responses that we got, carers feel a lot more calm. And this is from many of the, a lot of the feedback we got, a lot calmer dealing with ISB. You can distinguish better between different types of problems, sexual behaviors. The approaches are different. And, many also shared using this in their personal lives, talking to family, talking to their own children, being more comfortable to bring up the topic, to talk about consent, which is so important, so relevant for children. You have a 17-year-old dating a 14-year-old, who have consensual sex, but, legally speaking, there are issues with consent. Or you have very sexualized young children, reaching out to older children for sexual contact. And how should the older children then react to that? So consent is so, so important. Talking to children is very different. And also dealing with their own shortcomings and their own triggers first. That also stood out for us. So just a number of the quotes that I have here that I really wanted to share. There are a lot of positive things, but we had carers saying that if I did not get this training, I would have overreacted. It helped me to take things lighter and not to assume. A carer said here, I now observe and analyze before I react. Most of them admit it. If they walk in on an incident, they have that moment where they either shout, scream, immediately start punishing, almost getting the, I almost want to say in Afrikaans, slaan die kinders met die vatdoek. They really have that, negative reaction, where many of them said now they can take a step back and decide how am I going to deal with this, responding in a more appropriate manner. Changes that many of them have seen, include children being more comfortable, to come to them and talk. Carers that admit it. They used to get children into trouble for things like masturbation, which, with reports being done and it, going up to the management where they can handle this in the home or in the house or in their little section, to talk more about things. Learners can come and share things with the carers more easily. She says here, I'm more comfortable bringing up the topic. It helps prevent more serious things. And that's what we want. We want, this conversations in the house for preventative reasons as well. Looking at their own knowledge and insight, they share the training improved my understanding of ISB, what is typical, what is atypical. I talk to the child first instead of reporting. Another one said what is appropriate and what is inappropriate and how to handle different cases, especially the small ones, the toddlers. I don't freak out anymore. People are uncomfortable when children show sexualized behaviors. And often with young children, it is very typical or normal behaviors, looking at the developmental stage of that child. Another one says here, the My Bodies book has been very helpful in making the boys understand more about their bodies. Then, at one of the facilities, that was very fortunate for us, we ran therapeutic groups of children involved with inappropriate sexual behavior. And that is what my colleague, Dr. Joan van Niekerk, is going to talk about later today. So please join her for that session. And at that facility, because we did training of all the care staff and we had a number of groups running there, we found also improved situation and feeling and almost a more relaxing environment in the whole facility with regards to inappropriate sexual behavior. One of the carers shared, she said that there have been less ISB in the facility. Almost every day there was a phone call regarding a specific child. Now they're receiving no phone calls about that child anymore. Another carer said that the group therapy with the boys and the training of the care workers in combination has helped. And we really saw this because we included the carers in the therapeutic sessions. Apart from the training, it really helped to get them to be comfortable to talk about these things and then lead to the boys understanding. Well, I'm saying boys, there are girls as well, just used to work with the boys, but with the boys being able to get to that point where they can take responsibility. Being punished, they push back. Working with them, they develop that insight and they can actually sit back and be like, okay, they can understand, I did this to this other child and how that other child might have been feeling. Very, very, very important for us. So some of the challenges that we have, just to go through that, and I'm almost done. Big challenge identified. Not all the facilities sent all the staff. Some sent representatives. They said that it's wonderful talking to their colleagues, but they feel they can't really share everything. They feel all the staff need to attend the training, and also on all levels, from junior to senior, from carers through to therapists and management, so that everyone can also be on the same page. One of the facilities also indicated that they've gone through this training, but the carers feel that the management still has a different way of looking at things, and the carers want to do it the way that they've been trained, especially with the child justice system. So to prevent that sort of, clash of ideas on how certain matters should be handled. So yeah, that is some of the biggest things that have been identified. And then another thing is further and more training on the child justice system and being involved in the child justice system. And I can tell you guys now, and I'm happy that we're at this specific conference. It was an amazing experience working with these carers. I, as a social worker, as a probation officer, from a personal point of view, think that carers can often be overlooked, whether people agree with that or not. That is my experience. And it was really wonderful for me to be working with the care staff and, supporting them and assisting them and also learning from them, because they are the ones that do this extremely difficult job of taking care of the children all the time. Our next steps going forward now is to collect the data from our outstanding 3 facilities, so that we have a clear overview from our full population, and then to complete our paper for publication, hopefully, with Dr. Joan van Niekerk supporting me in that. So to summarize, I believe, from my point of view, that training often occurs once off without an opportunity to ensure implementation and application. And often training is not need specific. It's not always what the people attending the training, it's not always exactly what they need for their work. This project now gave us insight into the successes as we perceive them of providing training for a specific and a real need of those attending, by ensuring also that the training occurred over time, not just throwing a lot of information at people, that it occurred in a very interactive and practical manner, and combining our training with the sharing of knowledge, with skill development, and also very important with self-care opportunities. We had muffins, we had coffee, we had debriefing, and it was really, really good experience for myself, for the colleagues that did the training with me, and I believe many of those or most who attended the training. Also, we, the trainers providing therapeutic work, we do consultation and we provide follow-up services to these facilities. So we like to keep our finger on the pulse, to call it that. And we believe that having this open communication between people that you train, not just having a once-off training, but having that opportunity for open communication would really lead to much more effective capacity development. Thank you very much.
Thank you so much, Rian, for that very important presentation. I, at this point, just invite the audience for any questions or comments. You can put in the chat a Q&A. Just to say, there was about 30 to 40 people in our session. So those are the ones you're speaking to. I have just two quick questions while I wait for the audience to type out. The first one is, in terms of programs where carers, like child and youth care workers, are facing the same issues in schools or community-based settings during their work, how do you think this training could be used or applied in those settings? And then just the second question, you might have mentioned it earlier, is this material freely accessible for people? Yeah.
Right, so the training program or the training manual is available to everyone that have completed the training program. I wouldn't say it's not freely available, and I'm speaking under correction, but I believe that Jelly Beanz as an organization is happy to share what they can with the people out there. The tools are definitely freely available. The Our Bodies book, the Voices of Hope, and I know even the new book, Rainbows of Hope, I think the name is even available free in PDF form online. So, Jelly Beanz, they don't want to hold on to information. They want to share. They want it to reach as many people as possible. With regards to your first question, if I understand correctly, so yes, we focused on the CYCC environment, but the main thing here is children in care. So I can run this exact same training program with foster parents. We can run it with any setting, group home setting. It'll be great for teachers. All the information is very transferable. Although we focused on training that specific group or that population, we can provide this to all levels of professionalism, all levels of people that work with children and in different groups, whether it's teachers, social workers, or carers.
Fantastic. No, thanks. Thanks for that. That answers those questions. Anyone from the audience? I see we don't have questions as yet. Suppose maybe they're all quite clear. Yeah.
Well, I hope so.
Let me just see. No, none as yet. I suppose if no one has any further questions, let me just check one more time. Are there any final comments that you'd just like to leave us with? Or?
Yeah, so I do hope that my presentation was clear, and I would encourage facilities to reach out to Jelly Beanz. Yes, the organization is small, they might not have the capacity to provide the training now, but they're open to a conversation to set things up for the future. That I know for sure. The publication will definitely be available, and I think it's important for us to also share it with all facilities. And yeah, so give Jelly Beanz a call, send them an email, talk to them if you have more questions. I'm still involved with them with research. I will hopefully be involved with online training with them, even though I'm based here in the UK now. My job here is going to be very related to what I did in South Africa. So yeah, and all the best for the rest of the conference.
Sure. We just actually have one question, or a few. Let me just read them out quickly. I think you answered this one. This question is, will the training program be available again sometime? Will the training be available again sometime?
Yeah, so I think the best thing there is to reach out to Jelly Beans, go on the website, send them an email, or give them a call. And like I said, it's going to depend on the staff availability. But I know that it's something that the organization wants to have available.
Fantastic. And then we have in the chat, you answered this, how do I access the training? You've just answered that. And then a comment more than a question is just to say, a child and youth care worker from Soutpan, I think that's Northern Cape of Free State, but anyway, I stand to question, but a child and youth care worker writes that she's very happy to be in the conference. She's learning things. So I think there's something she's from your presentation.
That's wonderful. Yes. I'm very, very glad.
Fantastic. Well, thank you again, Rian, for the presentation. Hopefully we'll be able to access your PowerPoint, and we can also put it on the download section in the conference platform to access. And thank you again, and we look forward to the presentation later with your from your colleague, Dr. Jones. Okay.
Thank you very much. Have a good day.
Thanks so much. You too.